Okay, well, welcome to this Symposium on TB and Diabetes Collaborative Activities. My name's Kerry Viney. I'm from the World Health Organisation. We've had a slight change of, well, not a slight change, but a change of our co-chair. Unfortunately, Gloria was unable to make it, and I might let you introduce yourself, Rudy.
Hi, my name is Rudy Tetard. I work for MSH, and I'm currently the Global Technical Lead for Infectious Diseases. Thank you.
Okay, so we've got a couple of objectives for this session today. So the objectives are really to describe some of the progress, barriers and challenges in the implementation of TB diabetes collaborative activities, to share some promising country experiences in translating global policy recommendations into practice, which is quite important, to identify some effective models of integration in resource-constrained settings with a dual burden of TB and non-communicable diseases, and to discuss some of the ways forward in implementing TB diabetes collaborative activities. So each of the presenters have been asked to sort of incorporate these themes into their talks. So we're going to run through 5 presentations sort of back to back and save questions to the end, if that's okay with everyone. And we have allocated about 15 minutes at the end for questions. So please write your questions down and feel free to ask those at the end. So firstly, I'd like to introduce the first speaker, Professor Tony Harries from the Union, Senior Advisor from the Union. And there is a bit of a typo for the title of Tony's presentation. On the program, it says that Tony will be presenting an update on the global progress in implementing TB diabetes collaborative activities, whereas in fact, he'll talk about addressing diabetes as part of the strategy for ending tuberculosis. So I'll hand over to you, Tony. Thank you.
Okay, Kerry, thank you very much, and good afternoon, everybody. So thank you for the opportunity to talk about this subject. In 2007, 2008, there were 2 key publications, the first by Catherine Stevenson and colleagues, and the second by Christy Gion and Megan Murray, both of them systematic reviews and meta-analyses, and both concluding that diabetes mellitus increases the risk of tuberculosis by a factor of 2 or 3 times compared with normal people. And since those publications, there have been papers confirming and endorsing this finding. There's also growing evidence that in people with diabetes, those who have poor diabetic control have an increased risk of tuberculosis. And conversely, those that have good case management and better diabetic control have a reduced risk of tuberculosis. So does this interaction matter between diabetes and TB? And the answer is an emphatic yes. We have a global escalating pandemic of diabetes mellitus. So we will see an increased number of TB cases. We also know that we have worse TB treatment outcomes in diabetic persons compared with normal people. In 2012, WHO did some estimates of the population attributable fraction of diabetes for adult TB, and they calculated this globally to be at 15%, which works out at having, in that year, over 1 million people living globally with diabetes-associated tuberculosis. And if you look at where these people live, India tops the league table, followed by China. Interestingly, South Africa comes 3rd, and then you have a number of big Asian countries below South Africa. In terms of TB treatment outcomes, we know that diabetes is associated with a possible delay in sputum culture conversion. It's associated with an increased risk of TB treatment failure and death during anti-TB treatment, and it's associated with an increased risk of recurrent tuberculosis after successful completion of treatment. And we also have some growing evidence that in diabetic persons who have poor glycemic control, they have even worse TB treatment outcomes. And again, conversely, if you improve that diabetic control, you can reduce the risk of death during TB treatment. So what I'd like to do now, giving you that background, is see how this diabetes-TB association plays its part in the NTB strategy. So just to remind you, we have pledged as a global community that by 2030, this is SDG 3, we shall reduce TB incidence by 80% compared with 2015, that by 2030 we shall reduce TB mortality by 90% compared with 2015, and during this whole time period, any TB-affected family will suffer no catastrophic financial costs. So we have three pillars that underpin this NTB strategy. The first pillar talks about integrated patient-centered care and prevention with a number of bullet point activities to essentially reach that goal. Secondly, the second pillar is bold policies and supportive systems, again with a number of activities. And the third is intensified research and innovation. So let's look at pillar one, and let's look at that activity, early diagnosis of TB and screening high-risk groups. So here, very nicely, we could consider screening diabetic persons for TB in countries where the TB prevalence is greater than 100 per 100,000. Now, we have developed a methodology, a programmatic methodology for doing this, so let me take you through it. Diabetic patients normally would come to the clinic about once a quarter, once every 3 months. So once a quarter, when they come, we should ask them the very simple question, has TB been diagnosed during this last 3 months, anywhere, for example, in a DOT center? If the answer is no, then we should screen that person for positive symptoms of TB, asking them about cough, fever, night sweats, and weight loss. And if anyone has positive symptoms, they should be referred for TB investigation, diagnosis, and possible treatment. So we've run this, if you like, programmatic algorithm in India, in China, in the South Pacific, in Africa, and also in some parts of Latin America. And you get a good yield of tuberculosis compared with passive case finding. But we have challenges. One of the first challenges is that diabetes doctors are not that interested in this extra work. They're more interested in fact screening for cardiovascular complications, for retinopathy, for nephropathy. We also know that if we pick up somebody with positive symptoms, our smear and chest radiography screening is not very sensitive. We miss cases of tuberculosis. Thirdly, the symptom screen is focused on lung disease, so we have a problem with identifying people who have extrapulmonary tuberculosis. And finally, and quite importantly, there are no structured recording systems in diabetic clinics, in complete contrast to what you see in the TB programmatic world. We also need to know a few other things. Is the newer TB technology cost-effective, for example, using expert MTB RIF? How often should we screen? Is once a quarter overkill? And should we do this perhaps once a year? Should we use a more targeted approach and maybe screen people who we think are at higher risk of getting tuberculosis? And should we screen for latent TB, although WHO currently recommends against this approach? There's some new evidence that has recently emerged. The risk of TB appears to be higher 1 to 2 years after the diagnosis of diabetes has been made, probably because the diabetes is out of control at that time. And the risk of TB is higher, not surprisingly, in those with greater TB exposure. So, for example, healthcare workers with diabetes working in health facilities, those who have poor glycemic control, and those who smoke heavily and drink heavily. Let's go back to pillar one. One of the activities is treatment and managing comorbidities. So here we could consider screening TB patients for diabetes and treating patients with dual disease. So again, we have a programmatic algorithm, and this is how it works. At the time of registration, we would very simply ask a TB patient, is there a known diagnosis of diabetes? And if the answer is no, we should screen actively to see if they have diabetes or not. And we can do this with an RBG, a random blood glucose. And if that is at or above 6.1 millimoles per liter, it means the person's at risk of diabetes, and we should bring them back and screen for a fasting blood glucose. And if that is at or above 7, then we can diagnose diabetes and refer to diabetic care. So again, we've run this algorithm in India, China, the South Pacific, Africa, Latin America. In India, we ran this in 64 health clinics and in 8 hospitals. We had very good results, good pickup of diabetes, persuading the Indian government to make a policy change to say that all TB patients henceforth in the country should be screened for diabetes mellitus. Now, the rollout has not been that good, but in some states it's been very good. So an example from the state of Kerala in southern India, looking at results basically between 2010 and 2013. So in green, this shows you the number of TB-registered patients, and in orange and the percentage shows you the number and proportion being screened for diabetes. And you can see that this successfully scaled up from 27% to 87%. And the yield pretty good, just under 20% of patients each year being identified with diabetes and obviously being referred for diabetic care. Now there's some challenges with this, and a couple of big challenges are as follows. When should we best screen? Should we do this at registration? Should we do this at the end of the initial phase of treatment? Or should we in fact wait until the end of TB treatment completely? And the issue here is that tuberculosis is a stressful condition, and TB increases the blood glucose level, so you can get a false positive diagnosis of diabetes. And secondly, how best to screen? So you could do this very simply by clinical, or by urine dipstick, or by random blood glucose, fasting blood glucose, glycated hemoglobin, which is HbA1c, or oral glucose tolerance test. And the problem here is that as you move from top to bottom of these screening tests, they become more sensitive, more specific, but they also become more costly and more cumbersome to use in a programmatic setting. So somewhere you have to find a happy medium in order to say we can do this in a program setting. With treatment, several challenges. We currently give 6 months of anti-TB treatment, and there's some evidence, not great evidence, that this is inadequate, and maybe we should be treating for 9 months instead. What are the best drugs for optimal drug concentrations? What about drug disease toxicity? For example, diabetes and isoniazid increase the risk of peripheral neuropathy. We know next to nothing about TB infection control in diabetic clinics. With recurrent TB, we need to learn much more about whether this is reactivation of disease or whether it's reinfection with a new strain. And finally, in these busy clinics, can we introduce lifestyle modifications and get people to stop smoking and have better diets? Let's go back to the pillars. Pillar 2, supportive systems, high-quality integrated care. Here, we can think about integrated diabetic TB care. If you have TB and diabetes and you go to most health facilities, you will basically be treated as shown on the left-hand side. You will visit the TB clinic for your TB, and then you'll have to go and visit the diabetic clinic for your diabetes. Surely we can do better. Surely we should think of integrated care. And in Mexico, where they did this, provided integrated care during the course of TB treatment, they had much better clinical outcomes and much better TB treatment success. And I think this has to be the way of moving forward. Pillar 2, prevention by addressing underlying determinants. So here we need to think about preventing people getting diabetes and caring for them better if they do get diabetes. So just to put this into the context of our NTB targets, if we look at the MDG era, which has passed, during that 15-year period from 2000 to 2015, we had an 18% decline in TB incidence. During the next 15 years, we are aiming for an 80% decline in TB incidence. Now, Pan and his colleagues last year looked at this, and they said if we continue with the current diabetic epidemic as we are doing, TB incidence decline will be less than 10%. So we've got to get a handle on diabetes if we really want to try and meet the end TB target. And finally, pillar 3, research and innovation. And all I want to do here is draw your attention to this great work being done by the TANDEM consortium, which I think Reinhard will tell you a bit more about in one of the lectures following this. But essentially, this is a European Union-funded consortium led by Radboud University in the Netherlands and by the London School of Hygiene and Tropical Medicine. They're doing great field work on bidirectional screening and treatment of people with dual disease in Peru, Romania, South Africa, Indonesia, and then doing great work in the laboratory, looking at biomarkers, looking at lymphocytes, macrophages, looking at genes to try and work out the causality or what causes people with diabetes to get tuberculosis. So, Madam Chair, just to summarize, with diabetes and TB then, we have a rapidly growing pandemic of diabetes. We really think this can threaten the NTB strategy by increasing the number of TB cases, by increasing TB case fatality, and by increasing the risk of TB treatment failure or TB treatment relapse, which of course further increase the number of cases. Now, we do have a global framework for collaborative activities. This was launched in August 2011 by WHO and the Union, but what we need is much more country-level action and more funded research to better understand the interactions between diabetes and TB. And if I can finish with my last slide, and just tell you about the BALI declaration, which was made in November last year. So in November last year, about 140 high-level representatives from government, from NGOs, from industry, civil society, from the research institutions gathered in Bali, Indonesia, and pledged that they would act within the SDG 3 health goal to really look at diabetes and tuberculosis. But they also understood that if we work within the broad framework of the SDGs, and we address things like poverty, clean water, clean energy, cities, we engage in strong global partnerships, these actually indirectly will help to reduce both TB and diabetes incidence and mortality. So thank you very much, Kerry.
Great, thank you, Tony, for that wonderful presentation, and you've stuck to time, which is wonderful, and that's a really nice presentation to set the scene. So I'm going to introduce Dr. Anil Kapoor, who is our second speaker. Anil is the chairman of the board of the World Diabetes Foundation, based in Denmark, and Anil's going to talk about some of the lessons learned from some of the projects on TB diabetes collaborative activities that the World Diabetes Foundation has been involved in. So thank you, Anil.
Good afternoon. Thank you for that introduction. It's always nice to follow Tony because he has set the scene. So basically what I would do in the next 15 minutes is to give an impression of the work that the World Diabetes Foundation has been doing in supporting this initiative about diabetes and TB. So it started in 2009, and basically when we realized that claiming to be a foundation that wants to support the care of diabetes in the most vulnerable populations in the world, it is very obvious that we need to also address the issue of the comorbidity of diabetes and TB. And you are all aware of these numbers. They keep on changing depending on which year you are looking at them, but primarily diabetes and tuberculosis are occurring in the same populations, and therefore the comorbidity is likely to be there. Not only is it there, but we also have an issue that people with this comorbidity are likely to face a higher economic burden. So as Tony mentioned, the situation on TB and diabetes before 2009, when we started working together, that the association was not in doubt, but there were limitations in terms of the understanding of what the situation was in the developing world. And as a result of this, we met in November 2009 in Paris, and you can see Tony and Knut in this picture here. And we started this work with the International Union Against Tuberculosis and Lung Disease, and we launched several initiatives to address the double burden of diabetes and tuberculosis in the developing world. First of all, to develop an evidence base, create models, and build advocacy. So over the last 6-7 years, the World Diabetes Foundation has funded about 25 projects in 16 countries, including the countries with the highest burden of tuberculosis and diabetes, that is India, China, et cetera, et cetera. Approximately about 5 million US, I hope it was 500 million. It's only 5 million, I'm sorry. 5 million US dollars funding has been provided to these projects, and as a consequence of this, we have basically been able to provide training, very basic training to healthcare professionals on the bidirectional screening, strengthen the capacity of about 500 clinics around these countries for the screening for diabetes and tuberculosis. And these projects have generated valuable epidemiological data on the dual burden of diabetes and TB. Now, what does diabetes and tuberculosis constitute in terms of the portfolio of the World Diabetes Foundation? Of the total funding that the foundation has made since its inception in 2002, and we started working with diabetes and TB only in 2009, about 4% of our funding has gone towards diabetes and TB. But given the context that TB is only less than 1% of what you see in a diabetes clinic, I think our contribution towards this is pretty high. But if you look at how much funding that has gone from our advocacy pie, almost half of the funding that we do in advocacy has actually gone towards advocacy for diabetes and TB. So almost 40% of our grants related directly to advocacy have gone towards advocacy for diabetes and TB. Tony referred to this about the TB diabetes framework, and as a consequence of the actions that we took together, this framework happened. And then this has been disseminated and widely discussed around the world. And you are aware of these key findings. I will not go into it. Tony already mentioned about them. And these are the publications that came out of it. Our capacity building, epidemiological and operational research initiatives to implement the collaborative framework have been supported in these countries. And as you can see, most of them are countries which have the highest burden of both diabetes and TB. If you look at WHO high TB burden countries that have been indicated in the end TB strategy, if you look at the ones that are in red, those are where WDF already is funding a diabetes TB project. Where the ones in blue, we have diabetes projects, and we can easily link up with the TB programs. And the countries that are labeled in gold or yellow are the ones where we have actually national programs that we are supporting, and we are actually pushing these countries to incorporate the collaborative framework between diabetes and TB in these countries. This is a slide that I borrowed from Ajay. From the Union. I'm basically describing the bidirectional screening and TB-DM project that we did in India and China, which Tony referred to, was basically getting stakeholders to come together, identifying sites and development of operational plan, implementation of the project for 9 months, and providing supportive supervision. Data was analyzed. There was another stakeholder meeting to create and inform policy and practice. And based on the work that happened here, we were able to indicate that if, for example, in China, where the average case notification rate for TB among DM was about 423 per 100,000 compared to 77 per 100,000 in the general population, a prevalence ratio of about 5.5. In India, about a prevalence ratio of 7.4. In Sao Paulo, where we have done some work with PAHO, where they had three sites, one in Sao Paulo and two in Mexico, where the findings were that in Sao Paulo, the prevalence ratio was 10.5. And in Tijuana, Mexico, the prevalence ratio between those people with diabetes, the case notification for TB was 14 times higher than in the general population. Similarly, a project in Indonesia, we are finding extremely high rates of tuberculosis in people with diabetes. The prevalence ratio in our project setting is roughly about 14.3. And in Cambodia, again, we are finding very similar high numbers of people that are detected amongst diabetics with tuberculosis. If we then look at some of the data that has been generated the other way around, the diabetes prevalence in cases of pulmonary tuberculosis based on the projects that the World Diabetes Foundation has funded, you will see across the board that people with tuberculosis have roughly about 2 to 3 times higher rates of diabetes than in the general population. And based on the studies in China and India, we said that if the protocol that was used in our project was to be rolled out nationally, then in China, roughly about 134,000 to 238,000 new cases of TB could be detected. And in India, anywhere between 200 to 300,000 new cases of TB could be detected amongst people with known diabetes. And we know that about a third of TB cases remain undetected and unreported. And so screening people with diabetes is a huge opportunity. Similarly, the other way around, where diabetes remains undetected in half the populations in the developing countries, screening TB patients with diabetes would give extremely high yields and will contribute immensely to new case detection. As a consequence of this work with the Union and WHO, as Tony mentioned, we were able to change policy in India, where a policy decision was taken that all the centers that have the ability to do sputum microscopy under the revised National Tuberculosis Control Program will screen people with tuberculosis for diabetes. And I'm happy to report that the other way around has also recently been taken, so all diabetic patients attending the NCD clinics will now be also taken and will be screened for tuberculosis. This announcement was made very recently. And while in China we were able to attract a lot of attention, and we had this commentary published in the Lancet, that kind of policy action we are still awaiting and has not happened. In PAHO, with our work with PAHO, has actually led to something very interesting, where in the NCD unit in most of the Latin American countries, they use a concept of the diabetes passport in the NCD clinics. And because of this work with PAHO, it is now a part of the NCD passport that all people with diabetes have to be screened for tuberculosis, and the other way around. So it is now becoming a part of this initiative which the Pan American Health Organization is starting to take in Latin America. In Indonesia, although WDF has not been directly responsible for this work, it was primarily an initiative of the Ministry of Health in Indonesia, supported by USAID. But again, in Indonesia, we have seen this policy action being taken, where bidirectional screening is becoming mandatory. In terms of advocacy, as Tony mentioned, we have been working together with the International Union and creating advocacy platforms and documents, and this is something that we co-authored, the looming co-epidemic of TB and diabetes, a call to action. Tony referred about the BALI declaration, and this was also a highly successful meeting. But there is an issue that still remains. The BALI declaration, there was an agreement that within the next 12 months, there should be a shared international repository for data ideas and research publications. And there was a commitment that a WHO-defined indicator to measure progress with respect to bidirectional strategies will happen. And this is something we are still waiting for. So the situation now with TB and DM is that there is certainly a better understanding and documentation of the TB-DM burden in the developing world. The collaborative framework is in place. Policies on addressing bidirectional screening and management of TB and diabetes are in place in many high-burden countries. There is a slightly better understanding of the programmatic challenges in addressing the co-epidemic. Diabetes is now included as an important element of the WHO NTB strategy, something that was missing for very long in any documents of the WHO talking about TB. The co-epidemic is receiving increasing attention from the research community, and leading research institutes such as the NIH this year has held two workshops, one in Washington and one about a couple of days back in Liverpool. But still there are lots of questions that remain unanswered. There are lots of issues that remain unanswered in terms of programmatic rollout. And as Tony mentioned, although it is something in the policy in India, it's still that needs to be done at each and every place in India, which is going to be a challenge. And similarly, there would be other countries where we have to do this work even more actively. So thank you.
Thank you. Great. Thank you, Anil, for that great presentation. So our next speaker is Dr. Richard Brostrom. And Dr. Brostrom is the Pacific Regional TB Field Medical Officer and the Branch Chief for the State of Hawaii TB Program for the United States CDC. And Dick is going to talk about charting the course for integrative care and sharing 5 years of lessons learned in the Pacific when implementing TB diabetes collaborative activities. So thank you.
Thank you, Carrie, and special thanks to the union. I think the meeting has been going great so far. The speakers last night and this morning at the plenary sessions were really inspiring. Love the direction that we're going, but lots of challenges ahead. Well, my challenge right now is to share with you what really is probably 8 or 9 years of effort to help to integrate the TB programs and the diabetes programs in the Pacific. I start with this picture, which is neither TB nor diabetes, but some of the work that I was called to do in Sierra Leone for the Ebola outbreak. And I list this for 2 reasons, not just to get everyone's attention. One is I rarely get to speak in front of folks who are from the African continent, and I just want to say how amazing it was to work with the local heroes who will never be recognized for the incredibly dangerous and tireless work they did to eliminate Ebola in their own communities. And the second reason is a reminder that as devastating as Ebola was, that entire epidemic is simply just 3 days' work for TB, 3 days last week, 3 days next week. And a reminder that if we look at the number of deaths from communicable disease since 1800, tuberculosis is still the undisputed king of infectious diseases. Anil gave a great talk a couple days ago at our NIH sponsored meeting and talked about diabetes and how it is really one of the central and key indicators for NCD success. So I'm calling diabetes the queen of non-communicable diseases. So that means, Tony, you get to be the king. Anil, you get to be the queen. You guys will have to work out who's in charge, although I know in my house which person would be in charge. And nowhere do these 2 diseases meet more strongly than in the U.S. Pacific. These are the islands that I have the pleasure of working with, beautiful places. I wish I could take you all there on a tour, but I would make you work because it's a place which is beautiful, as you can imagine, but it's also has very, very serious healthcare problems. Diabetes being one of the main ones, and you can see that if you can see that, from the STEP survey, several STEP surveys done in the islands, that diabetes rates are as high or higher than anywhere else in the world. TB rates are also very high. The diabetes rates are so high that they've actually declared war. The leaders have declared war on diabetes. And in the North Pacific, the public health directors have declared a public health emergency. So the funds that are supposed to be used for smallpox and anthrax and pandemic influenza are turned towards helping to control the devastating effects of diabetes in the community. We've talked a little bit about how diabetes complicates care, and with the great work of Megan Murray and Megan Baker and the folks who are in this, other folks who are in this room. We know that diabetes does greatly complicate TB care. It increases our number of TB cases. It makes TB harder to diagnose. It makes TB harder to treat. It increases our risk of recurrence and increases the risk of death during treatment. So for us in the Pacific, it's not at all an overstatement to say that diabetes is indeed the HIV of the Pacific. With high rates of diabetes and TB, we were called to bring change. And even before the framework came out, we began to try to structure some rules so that we could take better care of these TB patients who also had diabetes, because there were so many of them. The framework has come out, and we have reorganized to run parallel with the framework and to be consistent with those great recommendations. These are more clinically based, and they're for the clinician in the TB clinic, so they know what to do when a diabetic patient is presented with them, and then some programmatic advice as well. I'm not going to go through them. We have at other opportunities to do that. But I would like to say that now that we're in our 7th year of work and our 5th year of implementation of these, we're starting to measure implementation. I wanted to take a minute to talk about that. We've had a survey that I created in 2010 in Hawaii that we gave to the Pacific Islanders. I repeated it in 2012, and then in 2015 we had another excellent meeting in Sydney, Australia at the regional union meeting there. And I'd like to present to you the results from 4 of the main questions that we asked for implementation on their islands. Those questions were about screening TB for any patient over 18 years old, any TB case, screening for diabetes, testing everyone with diabetes for both latent and active TB, a tougher one. Consider extending TB treatment for 9 months for TB diabetes cases, and finally to provide basic diabetes education to TB diabetes cases in TB clinic. So for the first survey, you can see there's 6 islands up there. The average is somewhere between considering but not yet started and doing this for some TB cases. You can see where I'd come from in Saipan. We'd actually been testing every adult with TB for diabetes for quite some time, but it hadn't yet caught on in 2010. By 2012, you can see that the numbers were improving, and at the recent survey has showed a remarkable increase in being able to test every adult with TB for diabetes. And the average is actually that nearly all TB cases are getting this done now. This is probably the easiest one to do, but I think might be the most important, because if you're doing this in your jurisdiction, you're going to all of a sudden discover these cases, and the data will drive the next steps. This has done is given us better data about the true incidence of TB and diabetes, and you can see for across the Pacific, the average is around 45% or so, but as patients get over age 40, it becomes the majority of patients that actually have diabetes. It's not the exception, it's the rule. The other thing to note is that oftentimes it's the diabetes or the TB clinic that's diagnosing the diabetes. 50% of patients, almost 50% of patients under age 50 with TB are diagnosed with their diabetes by our TB program. The second indicator was a tougher one, to test everyone with diabetes for latent and active TB. You see lower levels of implementation here. This is a tough one to do. It has improved some. There were 2 studies done, one in Micronesia and one in the Marshall Islands, part of operational research. With Tony and Carrie and the group, we were able to put these together and publish them. There has been some declination, actually, in compliance here But other places like Palau are now doing, all of their diabetics are being screened for latent and active TB. Part of that research was done in EBI, and they enrolled 353 diabetics. Only 213, we started with the TST here, only 213 were able to complete their TST reading. Obviously, one of the problems with using a TST. But they found that 88 had a positive skin test, and of those, 77 had latent TB and 11 had active TB. So what that meant was that the rate of diabetes, or TB in the diabetes clinic in EBI was over 5%. And the prevalence ratio, I think that Anil showed for EBI was around 20. The other important thing about that is that not only were these cases identified, but their TB was identified early. And that had an effect on mortality for patients in EBI in that 3-year period that had TB and diabetes, and the program was called by the ER because the patient is in the ER with TB and also has diabetes. Mortality was exceedingly high. This has improved since then, but at the time, 45% did not survive TB treatment. However, for the patients that were screened in diabetes clinic and their TB was found there, only 1 out of the 11 died and was unable to survive TB treatment. So that early diagnosis made a huge difference for these fragile patients, and is another good reason to attempt to do screening when you can, if there's enough cases and your epidemiology supports it. The third indicator was to consider extending treatment to 9 months. You can see this wasn't done very many places other than CNMI, but recently the interest in treating longer has gone up, and at this point most patients are being treated for 9 months if they have diabetes. Obviously this is outside of ATS standards, and although there are several countries that are doing this, so it's not really that radical. But if you look at our data now with several thousand cases, in general, adults that do not have diabetes and non-cavitary TB, this is the percent that were treated at least 8 months. You can see that folks with diabetes and cavitary disease, and there are a lot of them, are treated, nearly all of them are treated for more than 8 months. Hopefully that's going to affect our relapse rate, but we don't know yet. Finally, my favorite one, providing diabetes education to TB diabetes cases. You can see there's, again, slow pickup, but a few places have really picked up this concept. Palau, again, is doing lots of great diabetes education for their TB cases. Here's RMI in practice. There we are in Hawaii. And here's our DOT worker even providing education out in the field. I'm happy to say we just put another order for these in because we wore them out. Which is wonderful. Patients love it. We've also shown commensurate drops in A1C during that same time. These are TB patients who had an A1C that was drawn every 3 months while they're being treated. We know that some of this improvement is certainly due to treatment of TB. It's going to improve their A1C. We like to think that some of it is because of our efforts and the efforts of our nurses to provide diabetes education. We don't know that yet. We don't quite have enough data. But I think it's promising for us and certainly encourages us to keep going. So there you see some summaries of implementation for those 4 fairly important areas. Of course, our long-term goal is to reduce TB deaths, and you can see TB deaths in the Pacific have gone down since we've implemented. I was able to look more specifically at whether people had, what the death rate was for those that had diabetes and those that didn't. And there's not enough data to say this is significant, but I love the looks of this line, and it appears that with good implementation, we've had a decrease in deaths, particularly among TB diabetes patients. I hope this continues as we measure and improve our data for TB outcomes in these fragile cases. Okay, one last thing, if I can indulge you for 2 more minutes. I might? Okay, thank you, Carrie. We had a lot of talk over the weekend in our session with NIH about disease silos, and everyone's railing against disease silos and how damaging they are for public health programs. I have a confession to make. I used to be a family doc, delivered babies, and did general practice. And now I'm in a disease silo, and it's kind of comfortable. I kind of like my disease silo. They provide for focus and clinical advances and research and can actually develop some expertise. They serve as a referral source for problematic cases. They provide a center for programmatic funding, and that's certainly essential. And they serve as a place for evaluation of data. But when those silos get extended down to the clinic level, I think that's when they get dangerous. One of the things that when I'm talking to our Pacific Islanders is I look out there and, I'd never seen a breadfruit tree or a mango tree till I came to Saipan. And I asked them if they've ever seen a silo. And the answer was no. So I'm going to share with you the education process that I shared with them. If you're in Minnesota, where I grew up right now, it's a breadbasket of the world, and you drive down the highway, it looks a lot like this on both sides of the road, nothing but corn. And if you're there in August and September, then they're harvesting that corn. However, it can't all go to market at once. You got to put it somewhere. The farmer wants to sell it a little bit every month. So they have to put it somewhere. And they put it in a silo. Long, tall, keeps that corn safe and dry and able to sell to market. And if you're in the Midwest, what you want to look for are the blue ones, because those are the harvestors. Only the farmers that are doing well have the blue ones, all right? So you can see this farmer here is doing pretty well. They've got 3 harvestors. And this farmer is doing really well. They've got 5 harvestors and apparently a lot of dogs. And this farmer here, well, I think this is probably the Donald Trump of farmers. But although we learn our diseases in silos, our patients don't respect our silos, and they don't understand them very well, and neither do the diseases. And Neil gave a great talk in Melbourne a few years back at the diabetes meeting about the interplay between infectious diseases and chronic diseases. And when you start to draw the lines, the silos begin to break down. We know HPV causes cervical cancer. Hepatitis B can lead to liver cancer. The Twar viruses cause heart disease. HIV causes a host of chronic diseases, hypercholesterolemia and diabetes and liver cancer, anxiety and depression. We know babies of moms who have influenza are more likely to have schizophrenia, a chronic mental condition from an infectious disease. Dental caries are related to heart disease. Tuberculosis causes strokes and heart attacks in the initial portion. And diabetes can link to worsening malaria, and then what this talk discusses, diabetes and TB. So that's not a very convincing group of silos there. The diseases don't respect them the way we do. So I think it's important to break down those silos, to bust them down, especially at the clinic level. And when we're doing blood glucoses in clinic, when we're teaching our patients about TB and diabetes, when we're bringing that educational component out to the field, when we're providing educational documents and referring people to see their private care clinician, we know we're breaking down silos and improving care for our patients. The last picture I want to show you is this one, because this one made me laugh. I'm sure this is a 16-year-old boy who got up and his dad said, "Yeah, you can knock the silo down today." So he drove his car over here and ran over and climbed in the tractor, and he's pushing the silo over, and I think he's going to have to walk home. So finally, when it comes to resistance, we talked about microbial resistance, but the resistance to change that Dr. Harry's challenged us all with is one of the biggest forms of resistance that we have to fight and work hard against. So thank you very much. Acknowledge the union, of course, and list a few of the resources that you can use for your TB diabetes programs. And remember to keep calm and look for TB and diabetes. Thank you.
Thank you, Dick. I think it's certainly important to maintain a perspective and not to get stuck too much in the dogma. Our next speaker, and I'm actually going to ask Professor Reinoud van Creevel to do the next talk. Although Dago has just walked in, we should probably give him a moment to settle. And Reinout will be talking about the TANDEM program, understanding tuberculosis and diabetes through basic studies and basic sciences, or through field studies and basic sciences.
This is not my presentation, but maybe you can put the next one. Well, it's a great honor, and it's also a great honor to be in the same line in the line with Tony Harris and Dr. Anil Kapoor and Dick Rostrom, who have done this work for such a long time. It's also been, and Bhakti Ali Shabana, who's here in the audience, we sort of stumbled on the interaction between diabetes and TB in Jakarta a while ago, and one thing led to another, and today I have the honor to present some of the data from the TANDEM consortium on behalf of many people working in that consortium. The TANDEM consortium brings together a very nice multidisciplinary group from 7 different countries and people with very different background, trying to both address operational, clinical, epidemiological questions as well as maybe more basic questions. Because if we think about TB and diabetes, we've heard about this. There's many TB patients who also have diabetes, but how can we best screen? Should we be looking in diabetes clinics, in TB clinics, and how can we do that most effectively and most cost effectively? We know the combination is associated with poor outcome, but actually for us clinicians, there's relatively little guidance on how to best manage patients with combined TB and diabetes. And then even less is known about why they actually do worse. What maybe from an immunological or metabolic or other point of view is the basis for the poor outcome in combined TB and diabetes, and actually what is the basis for the increased susceptibility in the first place. So are there genetic or other factors underlying the increased susceptibility? And so basically these are the 4 questions we try to address in the TANDEM consortium. So for instance, starting with the last question, so how can we explain increased susceptibility? One can start and study this in vitro, and this is what some of our consortium members are doing. So the interaction between a macrophage and the mycobacterium. Diabetes is not a simple disease, it's a syndrome, and there's a multitude of abnormalities or changes in patients with diabetes, hyperglycemia obviously, but also lipid abnormalities and oxidative stress and insulin resistance or hyperinsulinemia. And then they take diabetes drugs, which may affect our host response. So any of these factors or in combination may account, and then genetics, of course, may account for the increased susceptibility. So just to give you one result, immunometabolism. This is a growing field, and not just in TB, but for instance in sepsis, the metabolic state of immune cells is important. And what we've learned in TANDEM is, in the in vitro work, is that triggering a macrophage with MTB actually alters its metabolic status. So in red, you see everything in red goes up, so the glycolysis goes up, but also lipid synthesis. And in blue, the Krebs cycle. Maybe some of you thought after med school, I don't have to deal with the Krebs cycle anymore. I have to warn you, this is becoming more important. The Krebs cycle is going down in a macrophage triggered with MTB. But the metabolism of the cell is not just altered by the mycobacterium. The other way around, the metabolic status of the cell is also influencing the host immune response to TB. So if we block glycolysis, the host immune response, for instance, to TB is reduced. You can study this in vitro, but you can also study this using patients, and for instance, integrating genotyping or RNA sequencing data or functional data, cytokines from patients with or without diabetes, and that through that process integration of those different layers of data, we are aiming to identify candidate pathways or candidate genes, which you can next again take to experimental work to try and validate. And this is also something that is ongoing in TANDEM. In the context of this symposium, I'll focus more on the field study, but this picture just shows you how the field work, the building of the cohorts, and the sampling of these patients for genetic studies and for pharmacokinetic studies and for gene expression studies and cytokines and flow cytometry, etc., how we can integrate to address these 4 questions. But now let me start with screening and the experience we've got in screening. You've heard from Tony already on how screening is conducted and screening algorithms. So let me start with the diabetes prevalence across the 4 cohorts. So you see in gray the crude diabetes prevalence, and in these 4 sites in blue adjusted for age, and then the black bar is the country data in the International Diabetes Atlas. What is very clear from the data we generated is, not unexpectedly, but is the association with age. And the second thing which you will notice is that a large number of these diabetes patients in TB clinics actually had previously been diagnosed with diabetes. So it is sort of previously known but neglected diabetes, which somehow comes back through the diabetes clinic. We may identify them for the first time, but in these 4 sites, a lot of them actually had been diagnosed with diabetes before. So how should we screen? Well, within the TANDEM program, we compared a number of different screening strategies. So one is just by asking patients, obviously, as a gold standard, we applied the laboratory HbA1c, but then besides that, we also evaluated point of care HbA1c, the random blood glucose, fasting blood glucose, a urine dipstick, and also the diabetes risk scores, which are being used. And we evaluated this beautiful work from epidemiologists in London alone or in combination to see what is the best way to do it. Now, in terms of accuracy and cost, the best approach across the site seems to be a random blood glucose followed by a point of care test if it's above a certain threshold. And the fasting blood glucose is promising, but still a bit impractical in ambulatory care. More of this data will be presented tomorrow. But what is very important, and that's the nice thing about working with a similar protocol across the 4 sites, is that actually there was not a single one-size-fits-all for the different countries. And that's easy to explain looking at this graph, which displays the HbA1c values in TB patients in the 4 sites. And you see that they're remarkably different. So the patients in Indonesia and Peru, the ones with diabetes, had very high HbA1c values. Now, any diabetes test you use in that setting will be very accurate, because it's very easy to distinguish the 2 groups. While you see in the Romanian side and in South Africa, the HbA1c values in the diabetes patient were more modestly elevated. And it will be more difficult, and you may need a confirmatory test more often, or a combination of tests, and the accuracy of testing in those settings is less. The other way around, we screened over 2,000 diabetes patients for TB, and using all patients got chest x-ray and a symptom screen, and for those who had either positive, they got sputum examination, and we identified 14 cases of definite TB, most in Indonesia, and some actually had already been diagnosed. Quite a number of patients had possible TB, so they had chest x-ray lesions or symptoms suggestive of TB without bacteriological confirmation. Possibly there's some overreading of x-rays, possibly it's because elderly individuals, they may have some scars on their x-rays, etc. So highlighting some of the challenges of doing this. And obviously the cost effectiveness is maybe doubtful. We're working on that. And maybe we should aim for some kind of risk stratification. Maybe we should screen the smoking diabetes patient who also have, maybe we have to come to some kind of risk score before exposing them all to screening or to repeated screening. A very fundamental question is, of course, whether a diabetes patient is more susceptible to becoming infected if exposed to TB, or whether a diabetes patient has a higher risk of disease breakthrough once infected. Many of these patients in these high endemic settings may become infected at a young age, but in some settings, maybe the infectious pressure, the infection is not saturated in adulthood, and maybe some are more susceptible to infection. Now, we don't have a direct comparison for this, but this is an interesting set of data from the Bandung site in Indonesia again. This is also done in the other sites, showing the rate of latent TB using IGRA in a diabetes cohort. So on the y-axis, on the x-axis is the HbA1c value. On the y-axis is the level of interferon gamma, the antigen level minus the nil, minus the negative, the control. And you see that there is no relation with the HbA1c value. We see no relation also with duration of diabetes or with any particular diabetes medication. We don't have an obvious control group, a good control group for this, but these data to us suggest that at least severity and duration of diabetes do not seem to affect the level of infection, both as a proportion in these different strata as well as the height of the interferon gamma production in this assay. The next and very difficult question is the clinical management. Well, actually, there's a range of questions. Tony already alluded to it from whether we should adjust our TB treatment, but for now I'll focus more on the diabetes treatment. So we don't know, and we hope to find out, we're following our patients in TANDEM for 2 years, whether glycemic control and better glycemic control actually improves TB outcome, because that's obviously what we would hope for. It's a good thing to improve glycemic control, and I learned from Dr. Proer a couple of days ago that the first, when you meet a diabetes patient, when you diagnose diabetes, that's actually a very critical period. You have to get in, hit early, hit hard. You have to do it right in the beginning to also save some of the diabetes-associated mortality later on. So one of the things we're doing in TANDEM is a pragmatic trial, which is actually aiming to see whether glycemic control in the context of TB treatment and all the things that come with it is attainable, and second, whether it's helpful. So the intervention is not one drug versus another, but more the standard, sort of a bit lenient monitoring. We have our 2-month, 6-month time points in TB treatment, or whether more frequent glucose monitoring and adjustment of medication according to simple algorithms will improve glycemic control. The primary endpoint is a 3-month HbA1c, and then there's a number of secondary endpoints, including TB outcomes and drugs and costs, etc. And obviously, our frequent encounters with patients may provide opportunities, as Dick showed, for counseling on patients. And here, we pinched this from the Pacific. We have our own leaflet. Bhakti had it designed and developed in Bahasa, Indonesia, to educate our patients on the things that are important. Glycemic control is challenging for a number of reasons in low-resource settings, health systems issues, the side effects, drug interactions, the tuberculosis itself, which causes insulin resistance, but also weight loss and changes in energy intake, as well as behavior of patients, compliance, etc. And this is, for instance, this is the effect of rifampicin on the levels, on the pharmacokinetics of diabetes medication. And everything in red, rifampicin reduces almost all oral diabetes medication. It does not interact with insulin, and it probably not, at least through hepatic metabolism, interacts with rifampicin, but with metformin. But maybe through the activity of drug transporters at tissue level, rifampicin still has an effect on metformin. We have measured metformin levels, and they actually go up with rifampicin in our patients. So we have to see whether that has effects on toxicity or on glycemic control. Insulin has its own challenges. A very important one is that insulin is not easily available in many both public and private health settings across the globe. So should we use insulin or metformin? Insulin has some advantages. No drug interaction, it's effective, especially in poorly controlled diabetes, but of course there's disadvantages. Metformin has some advantages, no hypoglycemia, it's widely available and cheap, but some possible disadvantages in terms of side effects, questions regarding its use in patients with kidney dysfunction, and questions regarding its safety, especially in TB patients. So in this trial, we use simple algorithms to guide the medical management of diabetes. And this trial started in 3 sites in Peru, Romania, and Indonesia, but we actually had to stop in Peru and Romania, and that underlines the challenges in doing this, because the TB physicians in those 2 sites just felt very uncomfortable about prescribing diabetes and felt they did not have the mandate. And just the picture which Tony showed, You have to send your patient somewhere else to get his insulin or metformin, which is ridiculous, of course. So we're continuing in Indonesia. We see a lot of hyperglycemia. So most patients qualify for insulin, but the insulin is not easy to use in that setting. Some patients refuse insulin, and then we experience quite some hyperglycemia. Metformin, on the other hand, also not always easy. There's quite a number of patients with side effects, and some of those side effects overlap with those of TB drugs, especially the gastrointestinal side effects.
Rhino, 2 minutes, please.
Yeah, okay. Things are easier in previously known diabetes, harder in previously known diabetes than in newly diagnosed diabetes. I'll skip this then. So this also, the consortium also tells us a lot about diabetes and the diabetes phenotype in this site. This is the HbA1c values in diabetes patients without TB in one of the sites. And there's a range of other problems, and the management of hyperlipidemia, hypertension, etc., in these settings just appears to be challenging, at least. So if you think TB is difficult, try diabetes in these sites. Action and retention to care, the monitoring of treatment, glycemic control, toxicity, comorbidities, and the management and prevention of cardiovascular disease. We've seen mortality, and it's probably associated with cardiovascular disease early in TB treatment. Cesar Ugarte from Peru phrased it, the TB may be a second chance for some of our diabetes patients. At least for 6 months, we engage with our patients, and maybe we have an opportunity to get them back in the health system and to get them on the right medication for their diabetes after the TB treatment is completed. So to sum up, we see variable prevalence across the sites, and of course I haven't been able to show you a lot of the data, but only some. I've shared you the experience on the screening. We still have some question marks regarding the TB screening in diabetes patients, but the diabetes screening in TB is a definite yes. The glycemic control and the clinical management of diabetes patients with TB needs further study, that's for sure. And in those studies, we should appreciate the heterogeneity. We see very different experience from the different sites in terms of the severity and the comorbidity of the diabetes, the ethnic background, the drugs, etc. And those type of studies like TANDEM may provide opportunities for integration of field and basic studies. And with that, I'd like to thank the collaborators within the TANDEM platform, and as well as the EU who is funding this project. And finally, I'd like to draw your attention to 2 posters from the TANDEM consortium and 2 presentations tomorrow, one from Cesar and one from Daniel Grint. I'm not sure he's in the audience, also on this topic. Thank you.
Thank you, Reinhard. Reinhard, can I ask you to take a seat here? At the end of this, we'll call all the speakers to the podium. So if you stay.
I forgot to mention one thing, and that I was a bit optimistic about my flight departure time. And that I sort of feel that I would be a bit nervous to stay on, but I spoke to Hazel Dockrell, and she said that she or Julia Critchley, who's sitting next to her, would be willing to take the questions. I'm really sorry for this. I'd be happy to communicate with anyone in the audience. My email address was there, but I'm getting a bit nervous.
Sure, we have to cope with that. That's fine. Thank you.
Thank you very much.
Thank you.
Thank you.
And can we call Daegu Jerine to step up and do his presentation? Daegu is the director for the Challenge TB program in Ethiopia, and he will be talking about using TB and HIV platforms for prevention and control of diabetes, and using the examples from Ethiopia. So bringing a lot of what we've heard today to the practicality of how does one go about this.
Thank you, Rudy. So mine will be more of a practical experience from implementation point of view, from a resource-limited setting. So I'll be talking about the service models, how to integrate and use existing practices to support detection and better management of diabetes in settings with limited resources. So people have been, this part has been well described. The evidence is very clear about the interaction between TB and diabetes has been is well summarized by previous presenters. But what I'm presenting here is a bit different. This has been known thousands of years ago. This is not something new. Actually, an Indian monk had described, this symptom, the combination, the interaction between diabetes and tuberculosis, as mechanical, and still we are discussing and debating about the evidence. Fortunately, we are now coming to a very good conclusion that we have now clear evidence to support the implementation of TB diabetes collaboration. But we also have another challenge, which is HIV. So when we talk about integrated care, we usually talk about integrating TB and diabetes, TB and HIV separately. But we are bringing a slightly different experience, which is how to integrate and use TB, HIV, and NCD services into one package. So I'll be talking about this experience, and this is the next slides. So this is just to show you about the discovery time, which is 1000 AD, about the combination, the interaction between TB and diabetes. And then we got the framework in 2011. And when you ask your colleagues, many people even don't know at the ground level about the TB diabetes collaborative framework, which was published in 2011. And we had more calls for action, especially in 2014, based on the pilot presentations experiences from Asian countries. There has been a lot of pressure and encouragement to continue to implement this action. So we did this as part of our commitment to take action and show that we can implement integrated service delivery for TB, diabetes, and HIV. We did this in Ethiopia. Ethiopia is a big country with 96 million people. And as you see there, it's among the top countries for TB, MDR TB, and HIV. We are the third, actually, in the center of that WHO recent report. But when it comes to diabetes also, we are among the leading, the top 5 African countries, with an estimated number of 1.8 million people with diabetes. This is according to the 2013 estimate. We might have even a more refined estimate for 2016. So the objective of this pilot work, so I'm presenting a pilot work, which is a combination of a project and some research component in it. So this is to demonstrate the feasibility of providing integrated clinical care for diabetes, TB, and HIV in setting with limited resources. So the approach we used, which I call the technical approach, is this was implemented between February and June 2015 in 4 hospitals. These are the district hospitals in 2 big regions of Ethiopia. So the interventions, what we did was, using the experience from TB and HIV programs, we developed an on-site orientation material for primary healthcare workers, mainly nurses and general practitioners and clinical officers. And we trained them on-site in these 4 hospitals. So one of the challenges was how to do the screening. So we have the tools for TB screening in ART clinics. We also know how to do HIV testing, but we didn't have any experience on how to approach a patient for diabetes. This is the reverse of what we hear from Europe. They have more experience in how to screen for diabetes, but we have more experience in HIV and TB. So in ART clinics, patients, we instructed, we gave an SOP for screening for diabetes and TB. In TB clinics for HIV and tuberculosis. And in diabetes clinics, we don't have a designated diabetes clinic in most places. They are treated everywhere, in every corner. But we designated, we said these are all the outpatient departments are the diabetes clinics. So patients in those clinics were screened for tuberculosis. We had no rationale for screening them for HIV because there is no particular risk of HIV among diabetic patients. So we provided some supplies, a glucometer, a lancet, cotton, and minor supplies, and also provided monthly mentoring and monitoring visits were provided by clinicians. So for the TB screening, we used symptom-based screening, which was followed by diagnostic tests. We used microscopy as a primary test. This was a test that we had in most facilities. In HIV screening, we use the standard national guidelines for HIV. For diabetes screening, we didn't have any tools and guidelines, or people didn't have clear information about. So we had to rely on two resources. One is a risk scoring system based from the published literature, and we also use a symptom-based screening checklist developed by our team. This one is to detect some acute complications. It doesn't really identify risk of diabetes, but we combined and used them. Diagnosis of diabetes was based on fasting blood sugar, and we also took the patient record as confirmatory if the patient is known to be a diabetic patient under follow-up. So this is just to show you the scoring system that we used. We had family history, age group, hypertension, waist circumference, current smoking, alcohol use were used as to prioritize patients who would be at higher risk of diabetes. And we had a total score, and then we used a cutoff point of 5 as high risk or low risk groups. And this is the questionnaire. This we developed. We didn't know whether there existed any symptom-based checklist, but we used this based on our knowledge and expert advice that these are the polysymptoms and some diabetes symptoms, and from the textbook to see if there could be any correlation also with the definitive diagnosis we had. So data sources, we use a checklist as a data source, and entry and analysis was done using SPSS. We also triangulated this with qualitative information. Since this was implemented under programmatic condition, we had several observations, discussions, and meetings. So we summarized outcomes of those meetings to look to see how feasible this implementation was. So the results, this is to summarize the yield of screening. As you see, the number of TB patients diagnosed is about 0.7, that means about 700. And this is threefold the national estimate for TB prevalence in Ethiopia. When we look at the DM and HIV and TB clinics, patients with abnormal fasting plasma glucose level were about 32% in our TB clinics, but among HIV patients, it was low, about 1.5%. In terms of detection capacity, this is exact reverse of the experience from Europe. When you look, we detected 6 patients, and 5 of them were already detected by the TB program. The patient was known. But on the other hand, among 141 patients with diabetes, only 5 were detected using the existing system. So we didn't have the capacity to detect diabetes, but we had the experience and the capacity to detect tuberculosis. So having a risk score of more than 5 also predicted a definitive diagnosis of diabetes. So this has also a potential to be used in such settings. So this is the summary of the qualitative information, the positive influencing factors and negative factors, or barriers and facilitators. So unlike our expectation, people had a strong sense of local ownership for the diabetes work. We thought people would be rejecting our proposal to implement diabetes in HIV and TB clinics, but people are very happy and very supportive. The regional health bureaus, the district officials, hospital administrators were very cooperative, and they actually own this process. Providing the supplies was also another positive influencing factor. Mentoring and supervision was also critical to ensure that the providers followed the guidelines. People are also motivated because they wanted to gain new knowledge and experience of treating diabetes. And existing tools and capacity in RET and the TB clinics were also very, very useful because we had registers, patient cards, well organized. So it was easy to mark a diabetes diagnosis on those registers. But when you come to the negative side, Symptom-based screening is not an efficient system for diabetes. We didn't have organized clinic in those settings, and reporting and recording tools were lacking. Nothing was there. Patients come and they go, and sometimes when you look at them, they are managing themselves, and nobody is actually organizing the follow-up for them. In ART clinics, again, the screening tool, and in TB clinics was a challenge. In ART clinics, the health workers complained about high patient load because they were asked to do more. And there is already huge burden of documentation and work. So in conclusion, from our experience, systems and processes that we put in place under the HIV and TB programs, they served as very useful entry points for diabetes care. But undetected DM is very common among TB patients, because there is no effective screening system. So in future, I think we need to look at those best tools and algorithms for screening DM. This should be a priority research question. And the trained staff, supplies, and mentoring guidelines and tools, they were essential for implementation of this. So the same tools and approach that we have used in TB and HIV can be used for diabetes care also. So currently we are, based on the preliminary result, we are now scaling up this under the Challenge TB project. We are going to implement this approach in about 80 primary healthcare centers, and we'll be sharing more lessons from our work. Thank you.
Daegu, thank you very much. I wonder if you can just come and take a seat here. We'll ask the other presenters to step up to the podium. And I'm sure, Tony, this brings back many memories for you.
Okay. While people are coming up to the stage, are there any questions? There are 2 microphones in the aisles there, so if you have a question, if you can step up to the microphone, perhaps just say your name and where you're from and proceed with your question. Thanks. Yep, we've got one question. Yeah, can you come down to the microphone? Great.
Thank you. Thank you for the very good presentations. I would like to ask a question regarding to the TANDEM experience. So in the summary, the experience regarding to the screening diabetes patient for TB, the answer is yes. And the screening TB patient for diabetes, the answer is maybe. So can I ask some, explanations like the maybe regarding to the screening TB patient for diabetes is mainly considered of the sensitivity or larger percentage of them already been diagnosed elsewhere or some other reasons? Thank you.
Thank you. Well, as you can see, Reinhard has had to run for his plane, so you've got me. I'm a TB immunologist, actually, so I may pass this on to my colleague Julia Critchley. But broadly speaking, what we were trying to do in TANDEM was we were also trying to recruit a cohort of patients with both TB and diabetes that we could use in our more basic scientific studies. And what we found was an extremely low yield when we went into the diabetes clinics. So that is at least partially why there's a maybe. It's just that we found so many more diabetes patients in the TB clinics than we did the other way around, which is, of course, no surprise if you think what the prevalence of TB is and you think of increasing that only 2 or 3-fold. However, it doesn't mean it's not important. So maybe I should pass this question back over to Julia. Do you want Julia Critchley from St. George's? Would you like to add anything to that?
Maybe, Julia, can you step up to the microphone, please, just so we can hear? Thanks.
I was just saying maybe I should pass over again because our Indonesian colleague actually identified most of the patients with with TB amongst the diabetes cohorts. So we did look at diabetes cohorts, patients attending diabetes clinics with known diabetes across the 4 different populations. And it was really only in Indonesia that we found more than 1 or 2 cases of newly diagnosed TB in the diabetes patients. In Indonesia, about 1.5% of the cohort of diabetes patients had TB. And I think the numbers, obviously we did not screen a huge number of diabetes patients. 1.5% is still quite important, but I think it will be up to individual countries and will depend on the incidence of TB and the size and perhaps ease of accessing diabetes patients in different countries as to whether that's a worthwhile strategy to screen diabetes patients for TB. How much, and I think there probably need to be some modelling studies to look at how much that will actually add or how much that will help approach TB elimination goals in each of those countries. I don't know if Bachi wants to add anything about screening diabetes patients for TB. Is he?
So Bhakti Alisjabana from Bandung in Indonesia leads the TANDEM studies there and was responsible for identifying those patients.
Yes, thank you very much. I tried to explain why is it so different. I think that we see that screening DM among diabetes patients shows quite a similar number among the countries, about 10 to 14% to 17%. But the TB in diabetes patient shows a very huge variation between Indonesia, South Africa, Romania. And I think it's because of the prevalence of TB among the Indonesian community is about 0.3 to 0.6%. And among diabetes is 1.5%. So actually, we show the 3 times higher TB among diabetes. And I think the huge variation between countries is related to the prevalence of the TB in those countries. Like I think in South Africa, we found it's about 1%. And in Peru is also about 0 point something percent. Mm-hmm. Does that answer the question?
Mm-hmm. Yep. Yes, I think so. Thank you.
Thank you.
Great. We've got someone here. Did you want to ask your question? Say
Yes.
who you are and where you're from?
Yes,
Thank you.
Jonathan Gallo from Johns Hopkins University. I just wanted to follow up first on that last comment. We've done some studies in screening diabetics in South Africa and in India, only about 600 or 700 in each, using symptoms and leading to gene expert following. And we found 0 cases of TB in both of those settings. So very low, obviously low prevalence. Also, but following up on the screening of diabetics of TB patients for diabetes, which we're also doing in India, where we have found 21%, normal number, what people are finding. And what we're finding, though, however, is that about 60% of them are newly diagnosed. But what we mean by newly diagnosed is they're very borderline A1C. And I'd like the opinion of the panel of just what do we deal with those? What do we do with those patients as far as the ones who are already diagnosed with diabetes? They're coming in with A1Cs around 10. They're already on metformin. They're showing a moderate decline of about 1 A1C level drop. They drop down to about 9 something over their 6 months of therapy. But for those who are newly diagnosed and they come in about 6.8, 7, by the time 6 months therapy is over, they're still at 6.8, 7. And I hate to put it this way, but should we care? Obviously, we want to diagnose people who are diabetes as quickly as possible, but should we be putting them on treatment for diabetes at that point?
Thank you.
Well, if they classify as being diabetic according to the international criteria, then obviously they have to be on treatment. But that treatment need not be medical treatment. It's about lifestyle and stuff like that. And obviously people with stress hyperglycemia, a lot of them might be just tipping off onto getting diabetes because of the tuberculosis stress. But to say that you don't have diabetes or that it will pass away is wrong, because these people are at extreme high risk of future diabetes. It's like gestational diabetes. We don't do anything much about it. And therefore, it's very important to use this as an opportunity to say, you're lucky that you have been detected to have this potential. If you don't take action, you'll end up with the worst symptoms of diabetes.
Well, that's the answer I was hoping you would give. We also have another 20 to 30% who are pre-diabetes, and we treat, and
I would say that the advice would be similar to them.
Right. So my question is, though, of all these screening programs that have been going on for TB, where we're finding very high prevalence of diabetes, I'd like to know how much of it is, it seems like most studies, it is already known diabetes, or seems predominantly, and you can let me know if that's true or not in China and India, where the big studies have been.
I think in most countries, barring, for example, China, in India, for example, when we do the screening, almost half of the cases that you detect are newly diagnosed. They were not known before. In countries in Africa, like we heard in Ethiopia, 5 out of 41 were known. So the same thing we're finding in Nigeria, where 67% of people were first detected because they were screened because they had tuberculosis.
And then flipping it the other way, screening the diabetics for TB, we're seeing predominant, how many new diagnoses of TB are you seeing as opposed to previously known?
I think it depends on the efficacy of the tuberculosis programs in different countries. If you have a very efficient tuberculosis control program, you are likely not to detect any new cases. But certainly you will detect cases of TB, and therefore you would need to give them attention, better attention, because they are at risk of TB failure and treatment failure, or things like that. A point I wanted to make about using risk scores for diagnosing diabetes during TB might be a little skewed, because one of the biggest risk element that comes in that is the BMI, and most people with tuberculosis would have lost weight recently, and therefore it might not be a good indicator. So one needs to be a little careful.
Thanks, Anil. It looks like we don't have any more questions, and we've come to the end of our time, and there's another symposium here soon. So I think we'll wrap up. So I'd just like to thank Rudy, the co-chair, and all of the speakers, and if we can just give them one last round of applause, that would be great. Thank you.